Hi guys, in our previous section we were discussing the respiratory tract infections followed by anatomy and physiology of the respiratory system, right? Anyway, let us continue with the anatomy and physiology. So, in our last segment we discussed until the branching of the bronchus, right? So, in this figure you can see the trachea here. So, as also you can see the cartilages marked here. Okay, so here is the carina, and at the level of the carina our bronchus divides into right and left lung respectively, right? So here is the first primary bronchi, and then this one is the lobar bronchus, then here is the segmental bronchi, and you can see the cartilages in the bronchial branching. Okay, then there is the terminal bronchioles and respiratory bronchioles, then the alveolar duct, and finally the alveoli. So this is the normal branching of our bronchi. So from trachea to the respiratory bronchioles. So here is the respiratory bronchioles, right? So from trachea to the respiratory bronchioles, this is the passage for the air conduction, whereas from the respiratory bronchioles to the alveoli, it is the passage for gas exchange. So normally our bronchi are divided into 22 generations, right? So initially from 5 to 11 generations are small bronchi, then 12th generation onwards the bronchial tree is not having any cartilages. So from here you can see there is no cartilage on the bronchial tree. Then from 16th generation onwards it's a terminal bronchioles, and our respiratory bronchioles are under 17 to 19 generations. So these respiratory bronchioles are the important site. So this is the transition zone which represents the conduction airways and the gas exchanging part. Okay, so our conducting airways from trachea to the respiratory bronchioles are lined with ciliated columnar epithelial cells. So here we are having mucociliary escalator mechanism, and there will be goblet cells, and they produces the our first produces mucus. So this is our important lung defense. So as the mucociliary escalator mechanism, our larger bronchi is also having mucus secreting glands in the submucosa. So in the ciliated columnar epithelial cells, for the topper layer we are having the goblet cells, whereas in the larger bronchi the mucus secreting glands are in the submucosa. Okay, so from trachea onwards respiratory bronchioles, it is the passage for conducting airways, right? So what is the function of our conducting airways? It is nothing but filtration and humidification of the air. So whatever the particles or any foreign materials are there in our inspired air, that will be trapped in these bronchus or bronchial branches. So from respiratory from the respiratory bronchioles, this leads to the next part, that is alveolar duct, and from alveolar duct it leads to the alveoli, right? So the respiratory bronchioles leads to our alveolar ducts and finally to the alveolar sacs. So these alveolar sacs are composed of many alveoli. Okay, so our tissues in the lungs are made up of parenchymal tissue, parenchyma, right? So these parenchymal tissues in the lungs are having elastic nature. So this enables our lungs to stretch when inflated and recoil during expiration. Okay, so do you have any idea how many alveoli are there for a human being? So an adult male have approximately 300 million alveoli in his body. Okay, so the number of the alveoli and the size of the alveoli depends upon two factors. So the number depends upon the height of the individual. Okay, whereas the size depends upon the volume of the air in the lungs. So the number and the size depends upon height of the individual and volume of the air in the lungs respectively, right? So there is a basic unit for the respiratory system, that is the respiratory bronchioles, then the alveolar duct and the alveoli. These all together are known as acinus. Okay, so many acinus together forms a large unit that is known as pulmonary lobe. Okay, so this is a pulmonary lobe. Okay, so our pulmonary lobes are the units of acinus, many acinus. So at the level of alveoli you can see our immune barriers such as macrophages, eosinophils, neutrophils. So whenever infection or inflammation occurs, these all are released from the alveoli for the defense mechanism. So our alveoli is lined with a thin layer of unciliated squamous epithelial cells. Okay, so here is a more clear picture of the bronchial cilia. So this is the colored electron micrography of the bronchial cilia. So you can see the cilia, it is thick and abundant, and that will be coated in mucus, and it helps in removing the particulate matter from our passage, air conducting pathways. Now coming to the alveoli. So as we said before, our alveoli is lined with the unciliated squamous epithelial cells, right? So here you can see more clearly the alveolar sac, alveoli, then the alveolar duct and the terminal bronchiole. So our alveoli is abundantly lined with the arteries and veins. Okay, so when a bowl is covered with the net, how it looks, so as in the same manner our alveolar sac also same. So our alveoli is having two type of special cells. Okay, that one is type 1 pneumocyte and type 2 pneumocyte. So this is the capillary. So normally the alveoli is covered with the capillary, right? So this black color indicates the capillary and this green one indicates alveoli. So these type 1 pneumocytes are having no organelles. Okay, so you can see this structure is not having any organelles and it is attached to the basement membrane, right? So mostly the gas exchange occurs through this type 1 pneumocyte cells. And coming to the type 2 pneumocyte, so this is having organelles and lamellar bodies and microvilli. So you can see nuclei, microvilli, and inclusion bodies in this type 2 pneumocytes. So, these lamellar bodies are also known as inclusion bodies. So, they are having an important function in the alveoli. What it is? It secretes and stores the surfactants. So, this reduces the surface tension between the alveoli. Okay. So, when the alveoli are in a pulmonary lobe, there is chance of surface tension, right? So this surface tension is reduced by the surfactant produced by the lamellar bodies or inclusion bodies within the type 2 pneumocyte. So this surfactant contains insoluble lipoprotein, for example, that is dipalmitoyl lecithin. So this forms a thin layer at the air fluid interface and lowers the surface tension. Okay, so our pulmonary surfactant is a mixture of the phospholipids and also it has specific proteins. Okay, so specific proteins such as A, B, C, and D, whereas the specific protein A and D are having antimicrobial properties. So these all specific proteins, that is A, B, C, D, so they provides the biophysical properties of the surfactant. So if the surfactant is not having the phospholipid, then it won't be having the therapeutic efficacy. So phospholipids are the main composition of this surfactant. So if surfactant is not there, what happens? When there is deficiency of surfactants in infants, it causes the syndrome, infant respiratory distress syndrome. Okay, so in such cases surfactant is deficient from the birth, whereas in adult if it is deficient, it causes the disease adult respiratory distress syndrome. So this is an acquired effect commonly caused after sepsis, pneumonia, traumatic damage, and major surgery. So, in a nutshell, our respiratory system have protective mechanisms of the airways such as mucociliary effect, cough reflex, sneeze, and gag reflex. So these all mechanisms are serve to protect the air passages. Now coming to the physiologic functions. So, there are mainly three physiological functions of the respiratory tract. They are ventilation, perfusion, and diffusion. So, what are they? Ventilation is the process of procuring air from the external environment via inspiration to supply the alveolus, after which it is subsequently returned to the outside of the body through expiration. In simple words, it is nothing but the movement of air into and out of the body. Okay. So, another main physiological responsibility of the respiratory tract is diffusion. So, this is measured by diffusion capacity for carbon monoxide. So, that one tests how well the gas in inspired air can cross the wall of the alveolar and enter the capillary. So this tests how will be the gas exchange in the alveoli. Okay. Then last and final responsibility of the respiratory tract is the perfusion. So this is necessary to maintain ventilation and diffusion, right? So, our pulmonary artery capillary they surround our alveoli and provide the physiological proximity necessary for the transport of oxygen. So, here you can see the diffusion of oxygen from alveolus to the capillary. Then from capillary to alveoli, you can see the diffusion of carbon dioxide. So this lining with the capillaries provides the proximity for the transport of oxygen and other gases into the blood supply and carbon dioxide from the blood back into the lungs for expulsion. So, now coming to the respiratory tract infections. As our airways are divided into upper airways and lower airways, respiratory tract infections can also be divided into upper respiratory tract infections, that is URTI, and lower respiratory tract infections, that is LRTI. Okay, so the respiratory tract communicates with the environment and allows the microorganism to enter directly into the respiratory tract and lungs. Hence, the infections of the upper and lower respiratory tract are very common. So, majority of the infections are self-limiting and they do not require any treatment. So, let us begin with upper respiratory tract infection. URTI. So, URTI is the common for almost all, right? So, usually it occurs during the cold months. I'm sure that most of us are suffering from URTI 2 or 3 episodes annually, right? So, the mean frequency of URTI is 2 to 4 episodes annually for adults, whereas in children it is higher. That is, the incidence of URTI among child is high. So let us see what are the upper respiratory tract infections. So here you can see our upper respiratory tract can be infected with the infectious agent and that can result in these following conditions such as otitis media, sinusitis, pharyngitis, laryngitis, epiglottitis, and finally rhinitis. Okay, so among these, the most prevalent illness is the rhinitis, that is common cold. So, most of our upper respiratory tract infections are viral in origin. So, how it will be transmitted to the respiratory system? How these microbes or infectious agent reaches our respiratory system and causes these conditions? So, the infectious agent can transmitted by aerosol, droplet, or direct from hand to hand. Okay, so how we can prevent that? Direct hand to hand contact is an important mechanism of the pathogen transmission, right? Hence, frequent hand washing or disinfection can limit the spread of the infection significantly. Prior to this period, many terms existed to describe inflammatory conditions of the ear, right? So some of it has been defined and some of that still awaits clarification. Anyway, let us start with otitis media. So let us see the definition for otitis media. So it can be denoted simply as OM. So coming to the definition, otitis media is the inflammation of the middle ear without reference to etiology or pathogenesis. In simple words, we can say it is nothing but the inflammation of our middle ear. Now coming to the classification. So otitis media can be classified into acute otitis media with effusion and Eustachian tube dysfunction. So otitis media with effusion can be acute, subacute or chronic. So this is the classification and we will discuss about each of these: acute otitis media with effusion, Eustachian tube dysfunction later. Now coming to the risk factors. So these are the risk factors which promotes the infection with the infection to the upper respiratory tract, right? So you can see the risk factors such as winter season or the outbreaks of the respiratory syncytial or influenza virus. So as we discussed before, most of the URTs are viral in origin, right? Attendance of daycare centers, lack of breastfeeding in infants, Native American or Inuit origin, early age of the first diagnosis, nasopharyngeal colonization with middle ear pathogens, genetic predisposition, siblings in the home, lower socioeconomic status, exposure to tobacco smoke, use of a pacifier, male gender, immunodeficiency, allergy, urban population. So these all leads to the development of upper respiratory tract infection, otitis media. Okay, so risk factors for otitis media owing to resist the pathogen include daycare attendance, prior antibiotic exposure, and age younger than 2 years. Thank you.